Nationally, between 13 and 27% of all emergency room visits are for non-urgent conditions, leading to about $4.4 billion extra in additional health care costs. What is an ER for? When should you go there? And what are your other choices? We are On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. In 2013, 130 million people visited a hospital emergency room. 130 million visits. Almost 1 in 3 of us. But only 1 in 7 of those visits resulted in hospitalization. Why are so many people using the emergency room for non-emergency treatment? Tonight, we hope to clarify when should you go to the emergency room, when you should wait, and schedule an appointment with your healthcare provider. To examine the state of emergency care and answer questions you may have, we are joined by ER doctors John Travnicek of Avera Emergency Room Medicine Physicians in Sioux Falls and Benjamin Aker, Avera Medical Group Emergency Medicine, Yankton. John, tell us a little bit about where you trained, where you're from originally. Where are you from?
So I'm from a little town, I actually grew up on a farm on south of Scotland, South Dakota, little town in southeast South Dakota.
A ranch boy?
No, farm kid, kind of a farm hybrid. My dad was an anesthetist, so he was in the medical field.
Oh, really?
Yep. I went to Scotland High School and then went to Mount Marty College and then straight a little further down to USD Medical School. And then I did my residency training at Regents Hospital, which is in St. Paul, Minnesota.
So, and then you came back to?
Then I came back and started working at Avera McKenna about 8.5 years ago.
So, and that training, did you think was adequate for what you're doing now?
Yes, definitely. The vast majority of emergency medicine residency programs, pretty much all of them, are in a large volume place where you see a broad array of things, and so it's going to train you to basically take care of anything that walks through the door, whether that's trauma, heart attacks, infections, whatever comes through, you should be able to handle it.
But more than 50% of the people who are ER docs have training in other fields, don't they? I mean, are they all ER trained docs?
No, it's becoming more and more, a higher percentage of the doctors are going to be residency trained emergency medicine docs, but there's still a large percentage of the care that's provided by good primary care docs, mid-level or advanced practice providers, internal medicine docs, so on and so forth. There's not enough residency trained emergency docs to put in every emergency department in the country.
Okay.
So.
And Benjamin, you're from where?
Spearfish originally.
Okay.
And then, undergraduate was down at USD in Vermilion.
Yeah.
And then I went down to Nebraska for medical school and then Texas for residency.
So what town in Texas?
Dallas, Parkland Hospital.
Parkland. So you were at Southwest, is that what it is?
Yes, UT or University of Texas Southwestern.
So you were in the emergency room where President Kennedy had been brought in. You
Yes.
weren't there when he was brought in, though.
Right.
You weren't born then, were you?
And not even close. In Parkland, it's a lot different now than it was in those days. Well, the practice of emergency medicine has now come into being,
Yes.
and when it wasn't there.
It was
back
not
then.
a field
No.
when I went through.
No, it was staffed by. At that time, when there was a gunshot wound, the surgeons were right there, and so I knew some of the physicians who taught me some of the trauma surgery were interns at the time, and so they could tell me some interesting stories about those days.
Those days and when Kennedy was shot.
Yes.
Yeah, I imagine there's some stories we could talk about later, but not today. But then you came back to South Dakota, and where have you been? How long have you been here?
Well, I came back to Nebraska for about 3 years, and then since then I've been up here in South Dakota for 5 years or so about 8.
Working in the Yankton emergency room.
I was in at Sanford and Sioux Falls for 3 years, and now I've been at Yankton for the last year or so.
And that's been good.
It has been. I enjoy it down there.
So it's a whole different atmosphere. The two of you are ER doctors. I can tell you when I came to Brookings in 1981, I did the clinic, and then I did the emergency room when I was on call, which was once a week, all day, all night, up until the next day at 7. And then someone handed the baton off to someone else, and then worked all the next day. And if I admitted anybody to the hospital, I'm the doctor for the person that I admitted to the hospital. So I was kind of the did everything kind of the deal. And I could say that I was sorely inadequate for my training in the emergency room. I'm so glad it's changed.
Well, that sounds like a lot of work to have to do all that together. As far as taking care of patients in the hospital, as an emergency physician in our training, we don't really have that so much because we never do it. It's just not a necessity.
Right.
And so we can focus our residency programs on treating patients in the emergency department. And when we come out of there, then we really take the time to do that. And the volume of the patients is different now than it was
It's a lot
in
more
your
than
day, a lot more.
Yeah.
So we really couldn't take care of patients in the hospital at the same time.
Right. So what would be a common emergency room thing? If you said 10 cases were your typical cases, John, what would be the 10 classic typical cases for your day? Or can you even do that?
That's part of the beauty of emergency medicine. I don't know if you have 10 typical cases in your day, but the common complaints, number one in almost all emergency departments is abdominal pain. And then number 2 and 3 are usually either chest pain or extremity injuries. So those are pretty much all emergency departments. Those are going to be the top 3. But we'll see, infections and fevers and, cough and upper respiratory things. Just quite a variety. I mean, that's the one beauty of emergency medicine. You kind of get to see a little bit of every situation.
Every scenario. There's no question about it. I mean, you've got to know a wide array of knowledge to handle it.
Correct. Our knowledge base is more broad than it is deep. I mean, we have to know a fair amount of the presenting thing, but then we don't have to treat blood pressure long-term chronically. We don't have to know a lot of those chronic treatments, but we have to know the first few hours of every emergency and how to work those things up and treat them.
It's kind of exciting. Yeah. But a lot of what you see is not necessarily needed to be seen in the emergency room. And they say, we were talking about it, 1 in how many do you think gets admitted to the hospital?
Well, I have to say that I disagree to a certain extent with the statistics that are very prevalent on that. And I used to feel the same way. And I think it's very common to look at the ending diagnosis that a patient has when they're leaving the emergency department. What were they diagnosed with? And to use that diagnosis to say, well, that patient didn't need to be there, or that patient needed to be there. So a patient who comes in with chest pain, 99 times out of 100, they don't have a heart attack.
Right.
But the emergency department, we need to look at that patient with a fresh set of eyes every time they walk in and say, is this patient having a heart attack? And if we look at the chief complaint, the thing that the patient said is my problem when they came into the emergency department, if it's chest pain, if it's abdominal pain, if it's an arm that's crooked, something like that, those things could be really bad for the patient. They could be devastating if it truly turned out to be that they have a heart attack or that they have appendicitis. And so what we're here for is to be able to rule out those diseases. And I think that sometimes politicians and policymakers don't look at that chief complaint, and that the patient is there maybe thinking, what do I have? But what we're thinking is, does this patient have a heart attack? Does this patient have appendicitis?
Worst case scenario observation.
Right.
You were talking about the idea of a fresh set of eyes. Your advantage is you don't know the patient, you don't know their history, you are a fresh set of eyes, and you don't look at it in a biased way. That's also your disadvantage, because the doctor who cares for this patient, or the PA or nurse practitioner on a long-term basis, knows them, has heard all these complaints, goes, yep, we've already worked that up 5 times, don't need to do it again. So there's 2 sides of that, isn't there?
Absolutely. I mean, in the emergency department, we only have a few minutes to build that level of trust that a patient would have with his or her family practice doctor over 50 years plus.
50 or 30 or 20 maybe.
Plus, yeah, probably. Well, depends on how much you want to continue practicing.
John, comments about that?
I'll add too, as far as I agree, it is a definite advantage to know that patient and having seen them before. The one thing I will say, and docs begrudgingly don't want to give a lot of credit to the electronic medical record all the time, but that has helped us a lot as far as being able to see what tests that patient has had. Have they had a CAT scan recently? What did their physician say last week when they saw him in clinic? And so if you're in a health system, a Vera, Sanford, whatever, it is really helpful to be able to see those notes. And so it's made it easier when I don't know the patient. At least I can see, oh, well, Dr. Holm thought this, or oh, they just did a CAT scan last week. So there's less medical waste, I think, because of the electronic medical records.
You see my records, don't you?
Yeah.
You do,
Yeah.
I'm afraid.
Yeah.
And he goes, oh, this
No.
guy went on and on.
Yeah, if you're in the Avera system, we see it.
You see it.
And you see mine.
Yeah. When we think of going to the ER, we imagine heart attacks, broken bones, or other trauma, but every once in a while, the ER docs are called on to deal with something less common. The chance of dying from a venomous snake bite in the United States is nearly zero, but we still need to be cautious of these slithery creatures.
When you work as long as I have in emergency medicine, you see a lot of interesting cases, and of course toxicology is similar. I think the most interesting cases are the ones either a challenge for you, for your skills, or they're a situation where an unusual occurrence happens. I think some of the interesting cases in toxicology are bites and stings, and we occasionally get rattlesnake bites. Those are always a challenge. The smaller patient, the pediatric patient, I can remember having a couple of those where you think of them as normally in a dose situation, you don't give as much medicine to a pediatric patient, but when you're dealing with a rattlesnake bite, you've got a same amount of toxin in a smaller patient, and so one of the things I learned early there is that you give pretty significant doses to those kinds of patients if you want them to have a good outcome. Document your swelling, because the swelling will change fairly rapidly and help you know whether you've had a serious envenomation or not. Usually these are extremity envenomations where somebody gets bitten on a leg or an arm. If they get a bite into an artery, for instance, they might die before they get to help. These commonly occur out in the rural areas. None of the first aid measures seem to be very helpful that we've studied, and you end up wanting to get to the AntiVenom as soon as possible. If you've got somebody who you think is acutely dying, of course, and they have an extremity bite, you know, a tourniquet, even an arterial strength tourniquet, so you're totally cutting out the circulation, could be helpful till you get some AntiVenom. Not a lot of good evidence that these things do much to change the prognosis. The AntiVenom seems to be the biggest factor. And then good supportive medical care. You know, the number of deaths per year is a small amount. It's just in the double figures or less. And so it's fairly rare these days to have death. Now that's in the United States. Of course, worldwide, that's very significant numbers.
I'm glad that we're here. We are not live, however, so hold your questions for next week, and if you have questions, email them to us and we'll try to get to them. But the story of the snake is really kind of fabulous, and because we're all afraid of snake bites and we hear all these stories. Do you have had experiences with snake bites in the emergency room, either one of you?
In residency, yes. And really what's interesting about snake bites is that it depends on your part of the country or the world,
right,
is what kind of treatment you're going to have. And in general, there's two types of envenomations, I think is how you say that. And one of them is the kind of the pit viper, which is the rattlesnake is one of those. And that causes necrosis or death of the tissue and causes some problems with...
I mean, it's this tissue destruction.
Yes, and that's where you saw on the video that we just watched, where some of that had happened to people's hands, and that can be really devastating to the arm or leg or wherever. And it can do some things with blood clotting as well. The other type of a snake bite can cause paralysis of the nervous system, but it's temporary. So if you can, in the emergency department, take care of whatever needs to be taken care of for that temporary amount of time, then the venom gets metabolized, meaning it goes away.
Yeah.
And so you might put the person on a ventilator for that amount of time. So those kind of snake bites are, I would say, more easily treatable if you're at the emergency department.
Right.
But if you're not, then they can be even more deadly because it happens so fast.
Right. How about this AntiVenom toxin? Do you know anything about the AntiVenom?
Yeah, it's very effective, and that's the mainstay of treatment is getting the AntiVenom into these patients, the ones that have symptoms. Now, occasionally you'll see a patient that has a dry bite and there was no venom injected into them and they just need observation for a while. But the venom is very effective, and getting them to the venom or taking the venom to them, which a lot of the helicopter and fixed wing services will fly out to central and western South Dakota and bring the venom to them sometimes.
Cool.
So yeah, it's not common in South Dakota, but we do occasionally see a patient.
So that AntiVenom is really that first type, the pit viper type of a thing, and you inject it into the tissue where it's affected, or do you give it to the whole system? Do you know?
Inject it as close as you can to the site, because what the medication is it's an antibody that's been created in a lab. And an antibody, if you remember from biology class way back when, will attach itself to some other foreign molecule in the body, and then your immune system can then basically rid itself of that once the antibody is attached. So you want to have that close as possible to that site if you can get it there.
So you kind of infiltrate it. You don't put it into the venous system of the.
You try to get it as close as you can to that area.
What about the first aid? So people are out there where you grew up, right? That's pit viper territory, and they are bitten by a snake. You know, the story is you cut deeply into it and you suck hard and you spit all that out, and that's gone now, right? Tell us what to do.
Sounds like a lot of fun, doesn't it?
Yeah.
There's a lot of things on TV that don't accurately portray the real treatment, and that's a classic one. Yeah, I mean the old, another one is get the bullet out. They're always getting the bullet out in the old westerns, and they drop it into the nice tin bowl. And, that's another. Sometimes they take the bullet out, but sometimes they just leave that bullet.
I think that's how Grover Cleveland died, wasn't it? That the doctors were trying to dig out the bullet. I think it was, or was it Garfield?
One of those guys.
Sorry, viewers.
All I can remember is that I was in the emergency room as a senior med student when all the residents were having their Christmas party. And the attending was the head of the surgery department. And the little kid came in having been shot, and it was into the muscle of the butt. And there was this bullet there. And he said, "You want to help with the surgery?" And yeah. So here I am, and he's having me cut down there. And then, of course, I found the bullet, dropped it in the tin pan, and went ding. And I said, "Can I have that?" And they went, "Absolutely not."
Yeah. No, but the what you see in the westerns where they try to suck the venom out, that does not work at all.
Sorry.
Does not work at all.
I got off on a tangent.
No, that's fine.
So there's been a lot of changes in emergency rooms. I know that just because we now have a patient-centered medical home, the doctors who take care of people for the long term commonly don't work the emergency room, and there are a lot of people who don't have a doctor or don't have a nurse practitioner or PA or primary care provider. They use the emergency room as their primary care provider. That's a problem, and it should be fixed, don't you think?
Yes, that is a problem because, it's a problem for the patient because in the emergency department, as you said earlier, Dr. Holman, that, we don't see these patients every day. And so I don't necessarily know what the patient's history is or what the best treatment for is or what they were treated with in the past. But it is a symptom of the problem that we have, excuse me, as a society. well, not necessarily as a society, but how we run our society and how we choose to treat the patients that we have. Part of that is a financial issue because people don't have the means to see a primary doctor, and there are other reasons too. But I absolutely agree that sometimes we do become the primary physician, and I think a lot of us are happy to see those patients that come to the emergency department, but we unfortunately can't provide them with everything that a primary physician could, and by that I mean preventative care, which is really what their family practice or their internist can do for them.
Yeah, John.
And we pride ourselves on being the safety net for society. We, because of federal mandates too, have to see everyone that presents. But we pride ourselves on people that fall through the cracks. If they just moved here, if they have alcoholism, if they don't have insurance, we see all those patients. But then, then we try to focus on seeing them, stabilizing them, or making sure they don't have an emergency, and then getting them back into the primary care network. Because really, in the long run, that's the big thing for the patient, is getting them a primary clinic, a primary doc, and letting them kind of quarterback their health care.
Yeah, I mean, wouldn't that be great if everybody had insurance? And I mean, now there's more because of Obamacare, the ACA. And everybody had a primary care patient-centered medical home. A lot of problems would be solved, and it would help you guys in the emergency room so you could do the things that you're supposed to be doing. In the big cities, it's a different story than it is in Yankton and Sioux Falls, so don't you think?
I think it's actually a lot worse in the big cities. The access to primary care is very poor, and so we're pretty lucky here in South Dakota that really, even if you don't have insurance, there's good free clinics and low cost community-based clinics, and so there's good access in South Dakota, comparatively speaking, although we still have our own issues, but much better than a lot of the inner cities. And those patients, some of them don't even try to get in because they know they'll never get into a primary care doc.
So you guys are from South Dakota, and I can tell because that's how you say South Dakota. How do you say South Dakota?
South Dakota?
Yeah, South Dakota. So I think that's it. We are fortunate here. There are a lot of other changes, though. Besides the training of the doctor or the PA, nurse practitioner that works the ER, there's a lot of difference in the ambulance crew and the emergency crew. Tell me a bit about that.
In terms of difference, can I have you clarify that?
Well, it used to be that the mortician would go out with his hearse to pick people up. I mean, now the ambulance is extremely well trained. I've just been watching the whole time I've been practicing. It's been getting better and better, and the training has become more extensive.
So emergency medical services is what we're talking about, EMS, over the years it has steadily progressed to a very efficient and well-trained crew that can not only just drive you to the hospital fast, but they can give you medicines, stabilize your condition, start IVs, shock your heart, all sorts of things.
Intubate you,
put a breathing tube into your lungs, breathe for you. So it's come a long way. And an extension of EMS also is the air care that you can get, helicopter and fixed wing. So we can get to a lot of these remote sites pretty quickly for these really sick patients. So EMS has, which is pretty much an extension of emergency medicine. EMS has really improved by leaps and bounds over the last 50 years.
Right, and that's a wonderful thing.
Yeah.
I think in our town, my mom was at my home one evening and went to bed on the couch and woke up screaming. We ran down the stairs and she was rolling in pain, having chest pain, and I called 911. And it's just absolutely amazing. Less than a minute, there was the police officer, and then a minute later, there was our ambulance crew. I mean, it was like you couldn't breathe twice, and they were there. It just blows me away how fortunate we are in our community. I know your communities as well.
Yeah, and I should say that even first responders now are trained. Back even a few years ago, the police force wasn't necessarily trained in how to give basic life support, how to do CPR, the chest compressions, and now they are. And so if they're there, they can begin that. And at least in my emergency department, I'm seeing many more patients now who the paramedics can say, the patient was found down, or they were acting normally, and then suddenly they passed out, and chest compressions were started within a minute, and they brought them here, and their heart was beating again, and they were able to be admitted into the hospital and find out what happened to them. Whereas, a few years ago, they wouldn't have gotten those chest compressions. Exactly.
They were dead.
Yeah.
What about the EICU, the ER? That's the new thing that's happened, and it just blows me away that is available. Think about it, the talent and the training of an ER physician or trained person like the two of you can share your knowledge to an emergency room in Timbuktu or small town South Dakota. Comments about that?
Yeah, it is very exciting. Avera eMemergency, we are in, I think, about 7 or 8 states now, probably 80 or 90 sites. Also, the prison system in South Dakota and long-term care nursing home centers too. But yeah, you can literally, they turn on their camera. You come in, you have a face-to-face conversation. You can zoom right in on their rash or look at their EKG just like you're in the room. It is very exciting to help those providers that may not have as much training as you, help just guide them. They just kind of need a little bit of guidance once in a while, and they're looking for it. They push the button, and they really appreciate your help.
Yeah, explain that a little bit better. How does that work? I'm in the ER. I'm the guy. I'm covering. I'm on call. In fact, I still do call, and I cover the ER while somebody is in there. That's the ER person, and I'm the backup person that comes in and helps, or I admit the patient to the hospital when they come in. How does the ER work?
So they initiate the call. So we're not Big Brother watching,
watching what you're doing.
Watching what you're doing. If you need help, they push
the button and say, "I need help."
Yep. You push the button on the wall, and immediately that goes to our phone. We answer the phone.
Do you man the ER?
Yep, I work over at the eMemergency telemedicine. That's about a quarter of our shifts. So they push a button on the wall. Our phone rings. They say, hey, we need help in room, whatever room they're in whatever city they're in. So Watford City, North Dakota, or wherever they're at. And we just dial them up. It's a remote. You just like you can run a remote at home. You just run the remote. You bring them in, and you're in the room in
watching the patient,
5 seconds.
Seeing the EKG, seeing the
and it's usually a wall-mounted camera at the foot of the bed, so you can you're a little bit above maybe, so you can kind of see everything. If there's 4, 5, 6 people scurrying around taking care of the patient, you're a little bit above them, so you can see the EKG, you can see the monitor, you can see that the nurse is giving meds, those kind of things.
So and you cover how many emergency rooms?
Don't quote me on the number, but it's 80. Over 80. Wow. I think our goal by the end of next year was over 100 or something like that. So, and we're in North Dakota, South Dakota, Nebraska, Kansas, Montana, Wyoming, Minnesota, and Iowa.
Wow. Without revealing names or towns or anything, give me a case of where it made a difference.
Oh boy, I mean, there's dozens of them, but a lot of times where we make a difference is us helping them do a critical procedure or action on a patient. So the patient is in extremis, their blood pressure has been lost, or their blood pressure is low, their heart rate's high, whatever, they're dying basically, and this is their last few minutes. And they know they need help. Sometimes they don't know what to give. Sometimes they know what medicine to give, but they don't know what the dose is. Sometimes we help them put the breathing tube in. We give them guidance on what meds to do and how any pointers. And so there's dozens of times where we make a difference.
I'll give you a case. I was involved with a person who is in extremis, and I had an EICU person, very similar to this. And so I'm doing the resuscitation. And when it was all said and done, she passed away. And I felt like I didn't miss a beat. I didn't drop the ball because this other person had all these other bits of advice. We tried them all. and still the patient died. I didn't carry a burden home that night.
And there are so many providers that work in the small rural areas. It's a one-doctor town, and they're on call by themselves.
24/7.
And they now say, oh, at least I feel like I've done everything I could. Our team did everything we could. And a lot of them say, oh, you know, I'm not going to work without telemedicine. I'm not, you know, if they tell their administrators, do not drop this because I won't work without telemedicine again.
It does cost some, but it's worth it.
Yes, yes.
It's important that you, as a patient, be encouraged to ask if an ordered test or treatment is appropriate. But often we're reluctant to question the physician. We do not want to be seen as a problem patient. Even those of us who know better sometimes hold our tongues when we should speak up.
This is a personal story. A couple of years ago, I had a torn medial meniscus in my knee. The sort of thing that's pretty common these days.
Yeah.
A knee injury, essentially. And I went to see an orthopedic surgeon and had to get arthroscopic surgery. No, someone I had never met before.
Okay.
Had to get arthroscopic surgery where they look in with that little scope and then they fix it. And I scheduled the appointment for the surgery. And when I scheduled the appointment for the surgery, the woman behind the desk said, okay, now it's time to go for your preoperative testing. And I had to get a chest x-ray and an electrocardiogram and a whole bunch of blood studies, none of which were indicated. Okay.
I mean, you're well otherwise.
I'm well otherwise. And I've told this story to a number of people, and the question that always comes up is, well, you're knowledgeable about this. This is something you're interested in. Did you push back and say, I don't need that?
Did you?
No.
So you got the chest x-ray, you got the EKG, the blood work and all that. And
I wasted a half day waiting in line for getting the x-ray, et cetera, that sort of thing. And I didn't want to be a problem patient.
Yeah.
I just didn't want to be a problem patient. So I understand how difficult it is. And I think that's one of the things we have to do. We have to inform patients. We have to make patients feel comfortable doing that. And we have to make physicians feel comfortable letting their patients do it.
Yeah. Well, Mike, I seem to have patients that ask me. But I think we need to really encourage those people watching this to ask your doctor, you know, do I really need that test? And look into the cost of these things, because sometimes they're terribly expensive.
Yeah.
That was such a joy to have Dr. Steve Weinberger, who is the head of the American College of Physicians, executive director, here as our guest about a year ago, and he gave that story, talking about the cost of health care. And one of the biggest costs is the emergency room. And of course, I'm not pointing fingers. I'm glad that you're here, and I'm glad you're doing a good job, and I'm not trying to put you in a spot. But I know that there are times when very excessive testing is done, not so much time taken listening to the story and examining the patient, but quick to do the CAT scan, quick to do this test or that test. And there's a lot of money lost in that, or money spent during that whole thing. Now, Benjamin, what's your response to that?
Yeah, I absolutely agree with you that you know, there's over-testing that happens all the time, and the emergency department is a big place for having over-testing happen. You know, things are happening to the patient really quickly, and we're in an environment where people have a high likelihood of being really sick, and so sometimes we jump to doing the test, and I think that is a detriment. There's kind of a myth that we have in the United States now that there's this huge cost of emergency departments, and more recently some studies have been done that have looked at the costs of care and been found that the emergency department really only accounts for about 2 to 4% of total spending in the United States in terms of health care. Now, recently, the CMS, which is a government entity, came out with some, and I think they do this every year, where they say exactly where the cost of money is going, from the government at least. And they found that 20% of the total healthcare dollars went to physicians and were really salaries. So physicians, nurses, CEOs, administrators. So 20% of all the healthcare dollars go to salary. So of that 2 to 4%, there's a very small fraction of it that is actually going to physicians. So I want to kind of dispel the myth that the physician is getting paid so much to do this, and they're just ordering tests because it's going to pad their pocketbooks. In the emergency department,
you don't get a penny for any test that you...
No, not me. Now there are some emergency physicians that are in a payment model where they do get more, but those are few and far between. And I think that's in a lot of ways for good reason, because in our practice, or I should say, at least I speak for myself, that what I want to do is treat that patient. I don't want to worry about how they're going to pay, or when we're talking about the individual person, I don't want to worry about the cost of that individual person, because what I want to worry about is, am I doing the right thing from the science behind it? Does this patient truly warrant having a CAT scan of their abdomen because they have abdominal pain? A lot of us, granted, will go right to that CAT scan, $3,000 right there to do that test.
And equivalent of 100 or 200 chest X-ray radiation
exposure is horrible. Yeah, and we are a big culprit for doing that too, I'll be the first to admit. So those of us who are trained in emergency medicine, a lot of that training does teach us to try to avoid doing those tests right away. And the majority of patients, thank you, in the emergency department with abdominal pain, especially children that the parent is worried about appendicitis, we can do the examination, we can do the vital signs, we can listen to the history. We may not have to do any tests beyond that. We don't have to do a blood test, we don't have to do a CAT scan, we don't have to do an x-ray. We can say, you know what, your child is low likelihood to have this illness. Let's take an observation period at home. Why don't you come back and see me if you have this, this, or this, and why don't we have you see your doctor in the next week to be seen for follow-up? And then most of those patients do very well.
Mm-hmm. And I would respond that there are some surgeons who say, and you don't need the CAT scan to say you need to take this kid to surgery for appendicitis. I mean, here's the data. It's not going to change that you're going to take him to surgery. Don't do the 100 chest X-ray radiation exposure. Let's just take them to surgery and take out the appendix if it's needed.
Right, and we're trying to do alternative testing like ultrasound now. It's getting more. And that's another big thing about emergency medicine, is that we come out of residency, many of us trained in the ability to do ultrasounds for lots of different things. Exactly, and that essentially is a no-cost thing to do, and it can tell us information very quickly.
Very important.
And no radiation.
Yeah, and no radiation.
Cost. I mean, I'll echo those sentiments. I think emergency medicine, on the one hand, it is relatively expensive compared to the clinic because we have to be prepared for anything 24/7, 365, and so we always have to have a certain amount of staff working. We have to have large amounts of equipment for anything from Ebola to chest pain to trauma to snake bites to whatever. So it is relatively expensive, and yet emergency medicine a lot of times gets a bum rap. I think we do only spend about 2 to 4% of the total healthcare dollars, and emergency medicine, probably like every field, has some fat to be trimmed, but there's still plenty of other areas that you can go into, and plenty of other areas that have fat to be trimmed if we want to make this more streamlined, more efficient, more economical.
Right.
So,
a little comment about end-of-life care in the emergency room.
That's a big one.
How many people who really might be an opportunity to let go? Their life is pretty miserable, pretty harsh, and we don't need to do the chest X-ray. We don't need to put them on an antibiotic. We need to give them palliative or comfort care, and yet we're driven in the emergency room. I'm just criticizing because you don't know them, and you don't have the right, really, you don't feel like you have the right to talk to the family. That is it okay to not do therapy? What's your comment about that, John?
I guess I would say we've got a long ways to go, but I think we're getting a lot better. It used to be physicians were never even trained in how to talk about that with the patient or with the family, and it was always just you were there to save lives no matter what. And now slowly each generation of physicians coming out of residency, I think, gets a little better. They talk about it a little more, and now there's numerous lectures and talks and things dedicated to it in their training so that they're comfortable with it. And so I think we're getting there, but we still have a long ways to go.
I don't care if you're an ER doctor or an outpatient doctor or a hospitalist, the care for the patient who's the end-of-life care, we're not very good at that yet as a group, and we need to do better. I think that's really true, just as you said. there's a reminder for any healthcare professional in the audience that the 35th Annual South Dakota Winter Conference in Emergency Medicine will be held March 6th and 7th at the Hilton Garden Inn in Sioux Falls, South Dakota. That means nurses, nurse practitioners, PAs, physicians, ER, walk-in clinic, students, all these people are invited to join. There's a fee, something like $100 or something?
Yep, 100. It depends on if you're a physician or if you're another healthcare provider or a member of the South Dakota's chapter of American College of Emergency Physicians. And there's a website that I'm hoping that we can show you that.
What is the website? Do you have it off the top of your head?
Yep, the letters SD for South Dakota, ACEP at what is it? It's up there on the screen right there at 2015.com. Thank you.
2015.com. And so you would encourage people to go to this meeting, and I would encourage people to think about this. All healthcare professions that would like to get kind of picked up on this thing. This is an opportunity for you, and I'm giving you some payback for your wonderful providing us for your presence here. And you're going to learn about infectious diseases and Ebola issues and emergency room medicine contracts and new blood products and all sorts of things. So SDACEP website for more information. Great. Okay. Let's talk about problems that can occur in the emergency room. One problem that I see is that it's a high liability place. If I'm practicing in the emergency room, I don't know the patient. They don't know that I care about them. They just see me trying. I'm in a hurry. I've got 14 people behind waiting, and I'm just kind of all business. And I might hold off on that CAT scan because of radiation exposure. And then there might be something missed that occurs in another week or 3 or 5, and then I am liable because they don't know me. They may be from a different town. So that raises your tendency to order more tests, does it not?
It does, and
is it real?
I think it is real. I mean, there's been lots of debate back and forth for medical malpractice reform and whether that would make a difference or not. But I think when people come, reducing costs. But I think when people come to the emergency department, they expect us to catch their emergency every time, or at least that's in the back of our minds, that they expect near perfection or perfection. And so it sometimes that weighs on us whether we're going to get that CAT scan. And that's the other thing. There's lots of other confounding factors. We may not know that patient. We may have 6 more patients that need to be seen that are even sicker than they are. They may have, alcohol on board or a language barrier, and so all those things factor in. It is, although we are lucky in South Dakota, so usually South Dakota and North Dakota are 49th and 50th on the malpractice risk versus traditionally South Florida is always quoted as the #1 worst place to practice for malpractice risk. So best place maybe for weather. But
liability issues, I know that's a sour topic, and I know that in Washington, in the Beltway, they say, it doesn't drive costs. I don't agree with them. I mean, they're saying it's overrated as a cost driver. What do you think, Benjamin?
Yeah, what you're talking about, they call it defensive medicine.
Yes.
In terms of raising the costs, because I, as a physician, may be worried that something horrible is going to happen to all the patients that come into the emergency department. Maybe I had a patient who had a bad outcome in the past. And so I'm going to just be ordering all kinds of tests if I follow that defensive medicine. And that's costs go way up.
Yeah. Do you feel like you ever have to? I mean, when you see a person who seems libelous?
I don't think I can tell.
Can't you?
Maybe some people can. I don't know if I have the skill. But I would say that might drive some to go.
Yeah, and I'll add, I think it does drive physicians to order more tests in a lot of cases. But if the physicians were evidence-based, most of the studies show that it isn't, the patient isn't going to sue as long as you communicate with them, do the right thing, provide appropriate follow-up, or if you're not better in 2 days. I think it's more our bedside manner and just the basics, bread and butter of emergency medicine that will keep us out of trouble. But the problem is it's still in the back of that doc's mind that they think that the CAT scan and the blood work is going to prevent a lawsuit, which usually it's not going to. But
Now, before the show, we talked about evidence-based medicine issues, and I have to say that when I was a younger doctor, I believed in evidence-based medicine. You have evidence that proves it scientifically. My comment to that is, now I realize that sometimes the evidence is influenced by the pharmaceutical industry or by profit. And there is marketing everywhere you go, and sometimes the evidence is not as clear. We don't have the evidence in many things. You have to just work on what you have, which is not enough. That drives the cost as well. Any comment, Ben?
Yeah, I agree with that. There's a kind of a big argument in the emergency department realm about giving thrombolytics, or the clot-busting drug, if you will, to people who are having a stroke. And there's just kind of from the advertisements that companies have had, there's this perception that patients have that if you give this drug, it's going to kind
Reverse
of magically do that. And we know from all the science that it does not do that. In fact, if they get better right away, it probably wasn't because of that drug. It's probably because they had a transient ischemic attack, also known as a TIA, or some people call it a mini stroke. But they get better, a little bit better later on after 6 months. But the risk of this drug is about 17% of major bleeding inside the brain or in the abdomen. So a lot of emergency physicians, I'm not sure if I necessarily agree, but they say they don't want to use it at all because it's too risky for their patients.
So it's been driven by the and I look at the American Heart Association. I used to be a big fan of it. I'm kind of critical of them right now. I know they've done a lot of good, but they make a lot of protocols. They make a lot of standards of practice, and they are so funded by pharmaceutical industry.
That's the big thing, is switching the funding so that the majority of funding isn't coming from the people that want more business, so that it isn't coming from big pharma and the device companies. Hopefully we're moving in the right direction, but it's still a big issue. I mean, there's a reason why a lot of these health systems have removed the drug reps and they're not allowed on campus anymore, because I mean, they wouldn't do it if it didn't influence us. They wouldn't give us, pens and free lunches and things if it didn't. All the docs say, oh, it doesn't influence me, or the providers, oh, it doesn't influence me, but the studies all show it does influence them. No, that's why they do it.
But I need to make some comment in defense of the pharmaceutical industry. Thank goodness that they are profitable enough to be able to develop new medications. And so there's got to be a balance there. I mean, I've dealt and worked with them. I was involved with the CME for our hospital for many years, and they helped us in providing funding for speakers to come to talk about the topics I asked, and I didn't use their slides. And we had a chance for people to provide CME to our hospital, continuing medical education. And so we're in a capitalistic world. A lot of good things have happened because of capitalism. We've got to balance it. It's a balance.
Yeah.
I think that's a healthy partnership that can be had in that from the medical practitioners and the pharmaceutical companies, pharmacists, as long as we as providers look at the science behind it and not the hype, if you will.
So we've got about 2 minutes for the two of you, but I want to say a couple words about chronic pain. Benjamin, what is it, and very quickly, what do people need to realize about chronic pain?
Sure, we see a lot of patients with chronic pain in the emergency department. The first thing I want to say is that we are there to see anybody who feels that they have an emergency medical condition. We want to see them. And maybe we end up saying, well, we think this is your chronic pain, but we want you to come in. So I don't want anything that we say today to limit people from coming in to see us. But if we end up thinking that you have a chronic painful issue, we in the emergency department may treat it differently from what your expectation is of the emergency department.
Hopefully not the narcotic injection. I think bad medicine.
Right. The narcotic, the opiates, have been shown in many studies for chronic pain to be not only not beneficial but also harmful.
Make it worse.
And we try to avoid that if we can. For acute pain that comes from an injury, absolutely, those have been shown to work very well for it. But we, as medical providers in the medical community, bear a lot of the burden, a lot of the blame. It's not just patients that are drug-seeking. Yeah, we have trained the population to believe that we can fix any problem with a drug, and we need to kind of take a step back and turn around. So I hope that the patients who come and see us in the emergency department will accept our treatment recommendations.
Yes, and not giving them the
and
shot.
tell us if it works for you.
Yes,
'Cause I think it will.
John.
Well, the other thing I'll add is with chronic pain, if they are on strong medicines, addictive medicines, narcotic medicines, it's a well thought out concept that all of that patient's medicines should come from one provider, either their primary care doctor or a chronic pain specialist. So we're very leery. We don't do refills of those kind of medicines. We're very leery of giving those patients more because we want to make sure that they're not taking too much, that they're not going to overdose, that they're not abusing it, and we want them all to come from one doctor.
So this is great. I appreciate this conversation, and we'll be back right after this.
Health Partners presents Home Flu Remedies. History suggests there are several methodologies to beat the flu bug. There's sweat therapy, leech therapy, snake therapy, and of course the ever popular shock therapy.
Want to know the best way to beat the flu bug? Get vaccinated. With the flu bug still hanging around, it's not too late.
Just this month, I had two strikingly different cases. Case 1, Mr. A called to say he was losing ground with back pain, weight loss, and bowel changes. I set up an appointment with blood work in the outpatient clinic for the next day. Case 2, Mr. B's daughter called to say he was developing confusion after a fall last week, and today his speech was garbled. I advised Mr. B's daughter to get him immediately to the ER for testing. In the U.S., there are two distinct places to obtain health care. The outpatient clinic is where your doctor, PA, or nurse practitioner will get to know you, your family, and your lifetime story. Sometimes called the patient-centered medical home, outpatient care provides for preventive care, continuity with long-term monitoring, and minor illness treatment. The most important goal and advantage for the medical home is, over repeated visits, to establish and develop a trusting relationship. In contrast, the ER is where people with major illnesses and severe injuries are provided care. It is the entrance place to go when you're sick enough that you may need to be hospitalized. It's expensive care, partly because they usually don't know you. They anticipate the worst case. Understandably, they do a lot of testing. And finally, in the ER, they must be ready for any extreme and serious case 24 hours a day, 7 days a week, 365 days a year. Too often, people with minor outpatient type problems come into the ER because they haven't established a relationship for care in the clinic, haven't the patience to wait for the clinic to open, or haven't realized how the ER can result in unnecessary expenses. Minor problems are clearly best treated in the outpatient clinic. To say it again, the ER should be where you go when problems are urgent enough that you might need to be admitted to the hospital. Of course, if you have a serious medical concern, without question, go to the ER. But please realize the value of the relationship with a primary care provider that is found in the patient-centered medical home. Mr. A's outpatient workup found metastatic prostate cancer, which was diagnosed and treated successfully with outpatient care. Mr. B had a head CT scan in the ER showing a large blood clot requiring immediate hospitalization and subsequent neurosurgery. He eventually regained consciousness and speech. The outpatient medical home and the ER are two unique places with separate purposes. It's important to know the difference. Well, this brings us to the end of our show this evening. I sincerely thank our fantastic guests, Dr. John Travnicek and Dr. Ben Aker, for their wonderful insight into the world of ER care. And don't miss their emergency room conference this coming March. What were the dates?
March 6th and 7th, 2015.
All right. Great. If you've not gotten your flu shot yet, call your healthcare provider and make an appointment to get your vaccine. Remember, February is the biggest month for flu in this part of the world, so we're not out of the woods yet, just yet. Wholeheartedly agree with former Vermont Governor James Douglas, who said, care shouldn't start in the emergency room. Almost always. And until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishbach Financial Corporation.